Your skin naturally connects with nature and recognizes the goodness of native ingredients, which is why AfriSense Toning Bathing Bar is packed with African ingredients. AfriSense, discover the secrets of African beauty for your skin.
All right, thank you for staying with the Monday Report. Just in time for this discussion on lung cancer, live from the Kenyatta University Teaching, Referral and Research Hospital. Did you know that between 90% of cases of lung cancer diagnosed later on, usually stage 4? Why? What are the symptoms? Are there any measures? Is it hereditary? How much does SHA cover? That's a conversation we're having with my panelists right here, and I'll start by introducing them. From my farthest left, Dr. Abdi Mohammed, Chairman, Social Health Authority. Thank you so much for making time. Dr. Helena Musau, a consultant clinical oncologist from KUTRH. Thank you so much for making time. Dr. Andrew Owora, respiratory specialist from the Respiratory Disease Unit at KNH. Thank you so much for making time. And Dr. Grace Kalwai, a medical epidemiologist from the National TB, Leprosy and Lung Disease Program, MOH. Thank you so much for making time. And Dr. Helena, I'll start with you. Before we even delve into the details, how would you describe lung cancer? What is lung cancer?
It's one of those that you don't want to get. It's a life-threatening illness. We catch it a lot of the times when it's advanced or late stages. And patients need to go through a very elaborate process before they are diagnosed.
So what happens? What causes it?
There are many things that are thought to cause it, but the single most common agent that we know is tobacco. And it can be in various forms, either inhalational, chewing. It's the one substance that is known to cause lung cancer. Okay. Other agents would be things like radon gas, asbestos that we used to use in roofing, firewood, poor ventilation, and other inflammatory conditions of the lung are also thought to contribute to getting lung cancer.
You mentioned that it's something you don't want to get. What is the survival rate for lung cancer patients in Kenya today?
So we have various studies that are giving us survival, but what we do know, even across the world, is that the survival of lung cancer is poor, it's quite low. We have a study that was done in the Kenyatta National Hospital where they were looking at lung cancer survival 2-year rates, and they saw it was about 66% in 2 years. But by and large, most of the patients that get lung cancer will succumb from the illness.
It doesn't matter how early it's diagnosed?
It does. Of course, stage does determine. The type of lung cancer also determines. The treatments you're able to get determine how you survive. So there are also other confounding factors that will lead to survival rates.
Okay. Dr. Andrew, how common is lung cancer in Kenya?
So cancer is increasing globally, and Kenya is not left out. Lung cancer is not the most common cancer. I can probably be able to say that. It's currently ranked at number 11 out of all the cancers from the various sources of data in the country. However, our concern is the incidence is actually on the rise. We do not know whether it's a true incidence or just because of the immense improvements in terms of diagnostics in healthcare that are probably now able to help us to actually figure out why people are dying from certain diseases. I always make this joke that when's the last time you had somebody saying alirogwa? Nowadays we know there's cancer that is actually contributing to the deaths that we have.
Yeah. Are we better at diagnosing it now, or is it increasing generally?
So we do not know, but the efforts that have been made, especially in the public health space and our government, previously there was a medical equipment service project that equipped all the 47 counties in the country, and now all the 47 counties in the country actually do have CT scans. Previously these were not there, so we cannot really say what the true incidence before that was. Currently we are now able to have CT scans, which you need to actually make a diagnosis of cancer, especially for the lung.
Are there any primary prevention measures? Because that's the first thing that then comes into people's mind. What can I do to avoid it? What happens?
So as my colleague has mentioned, Dr. Elena, about tobacco as one of the biggest. So that's tobacco is the leading known cause associated with lung cancer in whatever form, from cigarette smoking to shisha, or what we call hookah, to vaping or velo. I know the young people in the audience probably understand what I mean. And this actually will put you at risk for lung cancer. From the data that we have, especially in men, because the men will actually give us this information, 90% of men who do succumb to lung cancer are actually former or current smokers of cigarettes or tobacco or whichever form of tobacco intake.
There's been a conversation among young people. I'm no longer a young person, but they speak about shisha and they say that it's better.
So the challenge with shisha is actually the way you actually consume it. Some estimates have reported that when you inhale your, I don't know if it's called a jar of bonga, yes, of shisha is actually equivalent to 100 cigarettes smoked. So
100 cigarettes.
100 cigarettes smoked. Velo is not any better because depending on the strength that you actually have, there's a 20 gram one, that's 20 cigarettes you're smoking at a go. You get a serious kick. For the ones who do it, probably they'll be able to explain to you this. They get a very nice kick, but that just tells you how much of this tobacco they're actually able to inhale. So in terms of prevention, public health, reduction in cigarette smoking has actually been the biggest contributor to the reduction in lung cancer, especially in the developed countries, because countries like the US and in Europe, their incidence for lung cancer is actually dipping, whereas for the rest of the world, the developing countries, Asia and Africa, our lung cancer incidents are increasing because we have many new people taking up cigarette smoking and inhaling these substances in whichever form. The other thing that I probably want to mention is indoor pollution. So basically inside your house. So what do you use for cooking or as your source of energy? Use of what you call biomass fuel, that's firewood, charcoal, kerosene, actually tend to increase respiratory illnesses in general, but also perhaps could also be contributing to the increased incidence of lung cancer because 50% of our lung cancer patients are female. They'll tell you they do not smoke, but there's something that is pushing lung cancers also in people who do not smoke. So you do not necessarily have to smoke to actually get lung cancer, and not all smokers will get lung cancer.
Okay. Yeah. Interesting perspective. And Dr. Grace, let me bring you in on this. How then should we enhance cancer awareness in the community? Because what Dr. Andrew is saying is very interesting. It's almost like a 50-50. There are those who smoke and they get lung cancer. There are those who smoke and they don't get it. There are those who don't smoke at all and they still get lung cancer. So how do you enhance community awareness or public awareness?
Okay. So there are a number of ways we can enhance that. And one being capacity building. Our community healthcare providers who are on the ground, whereby they'll be able to educate the community on the signs and symptoms of lung cancer. Additionally, educate them on the preventive measures they need to take to avoid, getting lung cancer through like the smoking cessation, using better gases for away from firewood and such that increases indoor pollution. Additionally, we can also enhance the awareness by letting the community know that there are advanced technologies for diagnosis. Currently, we are also having the AI aided radiographic means of diagnosis. So those are some of the ways. And
so we're currently using AI for early detection of lung cancer?
Yes, we can. Okay. Yes, we are.
Okay.
So this is through AI-enabled chest X-rays. So from the chest X-rays, we can be able to diagnose not only TB, like for instance in the TB program, but also we are able to catch on like subtle abnormalities that could be lung cancer or other lung pathologies like chronic obstructive pulmonary disease, which is also a risk factor of lung cancer.
Okay.
Yeah.
And Dr. Abdi, the question on everybody's mind is how much of this does SHA cover?
A lot. Cut the benefits and the cancer. So comparing to what NHIF used to cover, we cover starting from the diagnostics, which previously was not there. And more so under the primary health care, we cover the screening. In as much as we have started with the first for cancer, which is the commonest, which is cervical, breast, prostate, and colon cancer. Those are the 4 main cancers that we have. So we start at the primary health care fund to do the screening bit, and then when you come to the social health insurance fund, then we do the diagnostic and then do the treatment, which previously was not there. And finally, pay for rehabilitation and hospice care. So basically the whole journey.
Yeah.
Yes.
You say the whole spectrum, so
Yes.
you can't exhaust the funds, is that what you're saying? Because many people will say that chemotherapy is extremely expensive. Is that covered under SHA?
Under SHA, if there's one thing that you are assured of is there's no exclusion, there's no age limit. And the reason why we have the Emergency Chronic Critical Illness Fund, which is government funded, is so that no one exhausts their shift limit. So there's no exhaustion. What happens is you just transition to the Emergency Chronic Critical Illness Fund. You use what you have contributed, then once the treatment, and that's what we are trying to push for, to work with the societies in terms of the different associations to come up with guidelines, clinical guidelines and treatment protocols that makes it easier for patients not to worry, do I choose this one or that one? So the treatment now flows, and that's what I'm sure the clinicians would like, so that they also don't have patients who are worried, what will happen if I exhaust, or what will happen if this happens. And we also don't want to put limits to specific treatments. Like, I don't want to say 10 radiotherapy or 20. The reality is different cancers need different treatment modalities. So you cannot lump sum everyone to specific modalities. And that's why we want it to be based on the guidelines, which we are working very closely with the association Dr. Helena chairs.
Okay. And Dr. Helena, are we well equipped as a country to handle lung cancer?
I believe we've come a long way, and we are doing a lot better than we were in the past. So we are able to diagnose lung cancer, so we can be able to do our imaging studies. That's all the way from X-ray to CT scan to PET CT scan. We're able to have biopsies taken either through the interventional radiologists, who may not be available in all the parts of Kenya, but we do have access to them, and or our pulmonologists, where we can do bronchoscopies. We're able to have treatments available. Our pathologists, before treatment, our pathologists are able to diagnose the lung cancer, the type of lung cancer. We're able to have access to molecular testing, and then we're able to give treatments, be it surgery for early stage lung cancers. We're able to do chemotherapy. We're able to do radiotherapy. We're able to do targeted agents. And even fancy techniques, as what we have here at KUTRRH, using the cyberknife to be able to just target a lesion in the lung and treat that.
There's been a big concern in terms of capacity when it comes to resources, and then there's a human resource perspective of it. Do we have enough respiratory specialist in Kenya, such that my grandmother in the village can access one, and they're not simply given either Panadol or some cough syrup?
So probably I'll answer that with regards to respiratory specialists. We have a dearth of respiratory specialists in the country. When you talk about respiratory specialists or pulmonologists, either adult or children, total, if I'm not, last I checked, is that we only have 30 respiratory specialists in the country, 30.
In the entire country?
In the entire country. 26 of them are in Nairobi, 2 are in Mombasa, and 1 is in Kisumu, and 1 pediatric pulmonologist is in Eldoret. That's it. We are...
So Wasingishu, Kisumu, Mombasa, Nairobi, that's all? That's it.
So the major towns basically are the only ones who are served. Kisumu has 1. Mombasa recently, they now have 2 pulmonologists. We're actually trying to build the capacity of these sites. We actually did a recent workshop last week. Myself and a colleague and my colleagues from KNH, we were at Coast General Hospital. We actually ran a workshop because it's Lung Cancer Month, and we did quite a number of procedures to actually be able to make a diagnosis of lung cancer in patients. Hopefully next year, we'll probably expand that. We've already gotten a request from Eldoret, a request from Kakamega, a request from Nyeri. So depending on our schedule, we'll try and help even the generalists who are there to try and help them to be able to pick up these diseases as we try and organize ourselves to get training available locally so that we can ramp up the numbers of respiratory specialists in Kenya, because I was foreign trained. Majority of the pulmonologists like myself are foreign trained. There's only a limit to how many you can train in that model. Currently, all of us Kenyans understand the situation that we are in, especially economically. And the government has been grappling, has too many things to balance out, but there is an effort to actually try and increase capacity. We are happy that on the equipment side, there's been quite a big improvement, but I think now it's time that the equipment moves with the human resource. Each county should have at least a minimum of 2 specialists, respiratory specialists, oncologists, to actually be able to manage the numbers of lung cancers that we have. Why should somebody travel from Busia all the way to Kenyatta for just a diagnosis of lung cancer?
Is that one of the reasons why there seems to be a lot of misdiagnosis and then the discovery of lung cancer late? Because we have very few specialists. All of them are in Nairobi, actually.
So the challenge that we have with lung cancer, the way it presents is indistinguishable from the other chronic respiratory conditions. People who have lung cancer may present with a cough, but so will an asthma patient, a chronic obstructive pulmonary disease, interstitial lung disease patient will come up with cough. So cough is not very good. They may cough blood. Patients with TB, cough is not very good. They may cough blood. Patients with TB will also sometimes cough blood. But there are telltale signs that you can actually be able to help you try and actually narrow down, especially if you have an older person. If we look at the average age of our lung cancer patient, it's about 50. So if you have an older person presenting with symptoms, respiratory symptoms, not only do you want to screen for the chronic, but you also want to think about cancer. Simply because the challenge with lung cancer is by the time you have symptoms, it's late. So we need to pick you before you have symptoms. Now, we've worked with the Ministry of Health and the National TB and Lung Disease Program to actually be able to do this by actually trying to initiate what we call bidirectional screening, so that when somebody goes to a TB clinic, okay, we are looking for TB, that we also have an alert to actually check for lung cancer in the same patient, because those 2 diseases are indistinguishable. If you have a lung cancer patient, then you also want to make sure they don't have TB. There are certain instances where we've had patients who actually have both at the same time, just to tell you how difficult sometimes it can be. But by and large, that's the model we are looking at, because for lung cancer, we may not be able to do screening. So for lung cancer, our aim is actually early detection, because if we're able to pick people early, they can go for their surgeries, because surgery is what is curative for what we call solid tumors. Like, for example, lung cancer. If you have that part of the lung with the cancer chopped off, you get some treatment by the oncologist, then you should be able to live a normal, full life. So that's where we have a challenge. But by and large, most of Kenyans come late because they come when the symptoms are there. When the symptoms are there, the disease advances.
But Dr. Andrew, how do you come before the symptoms?
Now, that's where early detection is coming in. Yeah. So, for example, we've talked, we've actually just done the cancer guidelines for early detection and screening. Screening will be for cervical cancer, breast cancer, prostate, I think, also is included there, and colorectal. Now, there are other screening modalities for other cancers. For lung cancer specifically, you can't screen the whole program because you do not know what clearly to look for. So what we are doing for lung cancer is early detection. So who's at early detection means you want to look for people at highest risk. Now, the people who are at highest risk are people who currently smoke or people who formerly used to smoke. And the number we basically use is 20 pack years. So if you smoke a packet for 20 years, you are high risk for lung cancer. Or if you smoke 2 packets every day for 10 years, then you're at risk for lung cancer. Now, this is where the community health volunteers will probably come in, so that if somebody has that history of cigarette smoking, then you want to actually try and find to detect these cancers early. Some patients have had what you call incidental, or you were in a matatu, there was an accident, you went and had an X-ray done, and we saw something suspicious, and that's where she mentioned about artificial intelligence. But artificial intelligence cannot replace the human being. At the end of the day, the diagnosis is made by a clinician, irrespective of whichever tools they have. So for us, the lowest hanging fruit is starting with people who are at highest risk. Do you smoke? How long have you smoked? 2, is there a history of lung cancer in your family? If there's a history of lung cancer in your family, we also need to check, because generally for tumors that tend to be hereditary, they tend to occur earlier in the subsequent generations.
Okay. Yeah. Interesting views. And Helena, let me bring in Grace now. You were speaking earlier on about AI. Is that where molecular testing also falls?
For molecular testing, I think Helena can actually...
Helena was can handle molecular testing.
I'm sure there must be some AI available in the pathology lab as well. But for molecular testing, this is done on the specimen or in blood, and we're able to find mutations in the cancer cells, and then we're able to give treatments to target those particular mutations. And so that is what we call targeted therapy. In other instances, we're also able to give drugs that take advantage of the body's own immune system to be able to fight the cancer. That's immunotherapy. So that's where molecular testing comes in.
How widespread is it in the country?
It is not very widespread. It's available in mostly the major cities. So we'll have it in Nairobi, Mombasa, Eldoret. Yeah. Yes, I think that's it. But they have access through satellite labs to be able to link to the main labs, so that we can be able to do the molecular testing. And we do have some access programs available for molecular testing in the country for lung cancer.
Okay. Grace, let me talk about, we are somehow agreeing from the panelists here that smoking is the biggest cause of cancer here. But we do have smoking cessation programs in the country, but are they effective? Do we have enough to begin with? I see Dr. Andrew disagrees.
They are present, and this is something that is managed by the Tobacco Control Unit. And at the community level, if I can start, where within the facility, we have the key messages that are geared towards smoking cessation. And we also have programs that help individuals who have, challenges stopping smoking. So I wouldn't say it is present, it is effective, but we can do more. And as a program, I think as we are reviving or bringing out our lung health division, this is something we want to really scale up at all levels of healthcare. Yeah.
Okay. And Dr. let me bring Dr. Andrew again on this. There's a question that there are people who go to the village hospitals with signs of lung cancer, but often they're just given painkillers. How can they be able to tell if they have been misdiagnosed?
So it may be difficult to actually be able to tease out lung cancer from other chronic lung diseases, as I mentioned. The probably most common chronic lung condition globally is actually asthma. So if you have a cough that lasts a long time, usually we use the word 2 weeks, you do not have fever, your appetite is intact, then TB falls lower down. And the reason why TB is important is because it's infectious. So for the longest time, we've all been looking for TB because that's where even most of the funding is directed. And this is because tuberculosis is infectious. So no country of its worth would actually allow people to acquire transmissible disease. And that's why most of the resources and most of the efforts have gone to try and actually look for TB, treat TB, and try and eradicate TB. Now, if you're in a far-flung place, you're in Lokichogio in Kenya, and you present with a cough, clearly does not, it's been there for some time, we probably might end up being treated for tuberculosis because there's been a lot of concerted efforts. But what we've been trying to do is to try and improve and increase the capacity of the healthcare providers, having forums like this one. There's also another forum that we'll be having to try and just increase awareness. We have a run coming up next month. I have to mention that. To actually increase lung health awareness. And the greatest challenge is, or the greatest hindrance has been access to imaging, which I am very happy our chairperson of the Social Health Authority has confidently said that, you know what, these are things that now will be accessible to Kenyans, because just by interrogating somebody, it may be difficult to actually make that diagnosis. You need to have an imaging test. The imaging test sometimes can be confusing. And that's why we now have advanced tests. So there's basic radiograph, there's CT scan, we now have MRI, we have PET scans. There are patients, even me as a pulmonologist, I've been unable to make a diagnosis and sent for a PET scan, and that's what actually was able to yield that actually this patient had lung cancer, because this patient has been treated for tuberculosis, does not seem to respond. One of the things that we've included in the early detection is any patient who's on treatment for tuberculosis in the Republic, within 2 to 4 weeks, if they do not show signs of improvement, because for tuberculosis, the first dose will kill 99% of the bacteria, should actually enter the path for lung cancer early detection. So 1 month, if you're on treatment, you're not getting better, you need to have your radiograph done if it hasn't been done. They need to be a request for a CT scan. And I'm saying this so that all the Kenyans can hear. If you have a nagging cough, you need to have an imaging test done. For some patients, we had an elderly gentleman, 74-year-old. He was lucky he had that. We actually found he had a tumor in his left lung, the lower part of the left lung. He had surgery done, 74-year-old. And, you know, rarely does this happen, but his lung cancer was found early, at 74 years of age. So imaging will go a long way. Of course, there are the diagnostic tests, the areas where you can actually be able to get a diagnostic, the biopsying. We still have, I think, about very few centers in the public side, but there's efforts, because this is basically an interventional radiologist. And right now there's local training, or a pulmonologist who will be able to make this diagnosis, large imaging.
So if you see anyone with a persistent cough, because I know some people have been coughing for a while, but it's not so much.
Correct.
It's just once in a while.
Correct.
So they should be tested.
They need to have their radiographs done so that we say their radiograph was normal. Then you can go down the path of probably they have asthma. Okay? Yeah, that's what they probably are asthmatic. But if there are abnormalities in that imaging test, if it's a radiograph, they'll need to have a CT scan done. And the CT scan will usually be able to tease out for us those many chronic lung diseases. There are many, there are about 200 of them, but we'll be able to tease out when you do a high-level test. Okay. I have to take a quick break, but there's a question here from Komen Robert. I believe Dr. Abdi can answer this before we take a quick break here. He says, my question is, who does SHA benefit? Today I was in Kakamega County Teaching and Referral Hospital. I wasn't assisted.
and I was told that all services I have to pay in cash from my pocket.
That's a very important question in terms of who does it benefit. I would say it benefits anyone who is a contributor under the Social Health Insurance Fund. And for primary health care, it benefits any Kenyan who registers. That's it. But if you haven't done any of those, he will not benefit in any way. The pathway, the only other way you will benefit is under emergency. That one you don't need to register, you don't need to contribute. It's emergency, it's emergency. But the other two, you need to either register at the minimum for primary health care or to contribute for you to benefit, especially in level 4, 5, 6 hospitals. Yeah. So looking at the hospital he mentioned must be a level 6 or 5. So that means you must use your social health insurance fund. It means not only have you registered, but you have contributed.
So the contributions from NHIF are not moved here? Because Robert has not told me that, but most of the time, if
you had paid,
should it be moving to SHA?
No, if you had paid, there are people who paid 1 year in advance, 2 months, 6 months. That one has moved, and it's there. But if you have not paid anything and you have not registered, then you won't benefit in level 5, 6, unless it's an emergency.
Okay.
Yes.
I have to take a quick break.
So sometimes those are the things that need to be cleared first.
Yeah.
Because you will say, I'm not benefiting. It's just that maybe you haven't done the correct thing.
Because I'm sure you've seen many Kenyans are complaining that they're paying out of pocket.
True. And there are many Kenyans who are being served. The last 1 month, the claims we received was slightly above 2 billion.
2 billion?
Shilling.
Okay.
That's benefit to patients.
Okay. And do we have the numbers of those who are registered?
Yeah.
How many are registered
14
now?
million.
Now they're 14
plus.
Million.
I think, I haven't checked today's dashboard. It's it's heading to 15 million now, almost.
Okay.
Yes.
I'll take a quick break, but I know there are quite a number of you who have questions. By a show of hands, how many of you have questions? I can see the front line here, the second line there. Let's have the microphones to them. We're back in just a moment, all right?